I'm going to talk about a little bit about the screening and care for surgery and chemotherapy patient. This is again an area of controversy. There is no good data available. Let me tell you that up front. Why are we screening? I think that is something that has always been a tussle between the medical group versus the surgical group. And what is the data that is there at the moment? So there is definitely increased mortality in patients undergoing surgery who actually have a perioperative SARS-CoV-2 infection. And this data has been is available now, and the overall pulmonary complications are also much higher. And these are the various predictors of mortality. Male sex, age more than 70%, and the ASA, I think it's Anesthesia Society grade of 3 to 5. If there are emergency surgeries, major surgeries, malignancy related surgeries, all of these seem to be quite high predictors of mortality. Predictors of pulmonary complications again were related to anesthesia, evaluation of patients, and pulmonary, and of the people who died actually as a result of perioperative surgical complications, it was due to a pulmonary complication that they actually died. 30-day mortality was high in people who went on to, of course, have an ARDS. So, is there evidence to say we should screen? Yes, there is evidence to say we should screen. This is again another patient, this is another study, sorry, where they compared surgical mortality and complications in patients with and without coronavirus disease. And as you can see here, there is no doubt that 30-day mortality is higher with COVID-19 infection. Complications are higher, pulmonary complications are higher, thrombotic complications are also higher. So should we screen? Yes, we should actually screen, definitely. So what are really the CDC recommendations? Consider non-operative approaches when feasible. Minimize the use of procedures or techniques that might actually produce infectious aerosols. Minimize the number of people in the operating or the procedure room to reduce exposure. Implement universal source control measures, which actually includes universal masking, including patients. So patients also have to be masked, hand hygiene, and physical distancing. So, what are the guidelines? There's really no universal guidelines, and this is a source of great frustration. Now, each hospital is allowed to develop their own guidelines based on the number of elective procedures, the occupancy in the hospital, the operation theaters available, the manpower, cost, availability of test kit, etc. The median incubation period is about 5 days. So hence in CMC protocol, we actually have a COVID negative report validity, which is about 5 days or so. What did they find in Brazil? This is actually one of the largest series. What they found is 7.6% of surgeries needed to be postponed due to a positive test. This was when Brazil actually was second in the world with regard to prevalence of SARS-CoV-2 infection. This is one protocol recommended. This is not what CMC is recommending. Please note, I would like to state it again. We are not recommending this, but this is something that has been actually brought up. So there are various protocols which have involved both a combination of PCR and antibody testing, simply because PCR positivity can remain for a long time. So that is the reason why people have actually combined antibody and PCR approaches, because as you know, viral shedding can occur up to 3 months or so. So PCR, so basically they recommend a PCR and antibody testing together. If the PCR is negative and the antibody is positive, go ahead and do the surgery. In the normal OR, it really does not require any kind of testing. If the PCR is testing and antibody is, PCR is negative, sorry, and antibody is also negative, again, you can carry out the testing. If the PCR is positive and the antibody is negative, you can technically postpone the surgery, assuming that this is likely to be an acute infection rather really an remote infection. So there are various approaches now with the rollout of rapid antigen tests. This may change, but as you know, at the moment, the availability of rapid antigen testing as recommended, they are very poor sensitivity as compared to an RT-PCR. So at the moment, the real-time PCR test is what is a test that should be recommended for screening preoperatively. So what are the pros and cons? Pros, it identifies asymptomatic carriers. It can actually lead to protecting the healthcare workers. And if not emergent, I think you should defer the surgery till the COVID-19 infectivity period ends. It can help us to put in appropriate IPC protocols in place and to protect both the other patients as well as the healthcare workers. It gives confidence to the healthcare workers, it boosts the staff morale, and of course, patient safety as well is important. Cons is that incubation period is 5 to 14 days. So just because you're negative just before surgery does not mean you'll develop it a little later. And yes, this has happened in the hospital. It happens everywhere. But that's the reason why we are advising universal masking, so that if the patient does become positive while in the hospital, you do have some protective measures already in place available. So RT-PCR setup is actually needed for most places. I know this is a challenge in situation where their molecular techniques are difficult to actually implement or difficult to do. Antibody testing alone is of not much use. You do need a RT-PCR setup. The problem with RT-PCR, of course, is a long duration of viral shedding, and generally beyond 9 days, you are non-infectious, but that doesn't actually change the fact that you can never be certain. These are median periods that we're reporting, and the viral shedding can be longer in some cases. So coming to the cases where there actually can be prolonged viral shedding, and this is in chemotherapy, cancer, and transplantation. Now, again, what is the prevalence and the mortality in cancer patients, and does it really make a difference? Yes, the prevalence in some series is about 3.6%, and overall mortality in this group is 30%, of which 92% was because of COVID. And yes, this is as compared to the cases who also had cancer but did not have COVID. Hematological malignancies seem to do much worse as compared to solid organ malignancies, and leukemias themselves actually have a case fatality rate of about 2.25. Hematological malignancies, especially, are problematic when you have recent chemotherapy, and even after adjusting for age and sex, you will find that there is an increased risk of death in these individuals. So this is a special group. Close attention needs to be paid to this group. This graph just shows you the case fatality rate, which goes up as the age advances. And this is no different from what you would find even in COVID-19 infection. Really the same pattern that you would see in COVID-19 even without cancer. So, but you need to pay special attention to hematological malignancies because that they themselves actually have an increased risk of death. What you find in the immunocompromised, and this is again a source of great anxiety, and you find that yes, immunocompromised individuals end up with more severe disease. There is no doubt about that. They have a longer course in the hospital, greater severity, and of course, increased days of viral shedding. So if you can see there, they can shed up to 40 days on an average, and actually in some cases up to 104 degrees has actually been reported. So how do we organize ourselves when you have patients who require chemotherapy, who require radiotherapy, who require transplantation, and what can we do? So I think this decision has to be made case by case basis, involve all the hospital infection control committees in your hospital and your virology departments, if you have, or microbiology departments, whoever is taking care of your RT-PCRs, and all three of you together can sit down and actually generate protocols for your transplant and chemotherapy patients. Health education for these patients very important. They're a very high risk group, and it's important to reduce their footfall to the hospital. They should be educated how to conduct themselves, strict and safe triaging procedures for these patients in the hospital, provide the drugs for 3 months or so, so you reduce them coming into the hospital, and screening very important before procedure, chemotherapy and transplant. And in some cases, especially in hematological malignancies, depending on the positivity, they actually modify the treatment protocols. So I think this is definitely recommended before chemotherapy and transplant. While they're admitted in the hospital, of course, important to emphasize, these are high-risk patients. If possible, infection control protocols have to be followed strictly, and single room isolation in these patients, if possible, needs to be actually followed. What do you base your treatment decisions on? Of course, the risk of acquiring COVID, the clinical status of the patient, are there oral drug available or optional regimens available for reduced hospital visits? And of course, tailor it all to cost and the cost benefit ratio, and tailor it to the age and comorbidities. And teleconsultation, whenever possible, will actually really help in reducing morbidity and mortality in this very special group of patients. What about transplant? Not too much data available. Transplant societies are just coming up with their guidelines. And are there higher rates of positivity? Yes, there are higher rates of positivity in end-stage liver disease, end-stage kidney disease. They're extremely prone to getting the infection, and then do end up with a considerable mortality as well in these populations.